Hello, everybody. This is Anne de Geest, and this is an insight. It's Friday, August the 7th. This is my clinical update. Um, a quick debrief on who I am. I'm not a doctor, but I've been a business person in the healthcare sector for the last 35 years, being very deeply involved in developing products and launching like product like pulse oximetry, which is the device that's being used to monitor your oxygen by putting a device over your finger, but also very deeply involved in devices in patient monitoring in the hospital setting, in the ICUs, in the operating room, and have invested in over 40 companies that are trying to change healthcare delivery. So I'm coming from this from a clinical expert on the business side. This is the clinical section. We're going to talk about symptoms. We're going to talk about long-term damage and a lot of information on infectiousness and transmission. So really stay for the ride. And there's a lot of new treatments that have come out. So please pay attention. So a quick summary there for people who haven't been here before is that there is a viral response that starts before you have symptoms, and we'll talk more about that. Usually start going away at 7 to 10 days, and then you have that cytokine storm, which is your own immune system overreacting there that creates the complication rate that gets people around 20% of the people in the hospital there. So the type of symptoms we're going to be looking at are very different when you're in the early stage. We'll talk about this. In the past, we've covered the hospitals, so I'm not going to spend too much time this week about this. So what do we know? Not too many changes since last week. At the high level there, more data showing that children are more contagious. They may not get as sick, and they have very low mortality rate, but it turns out they may be much more contagious than an adult. And that's a concern for school reopening. We clearly have doing a much better job at treating people in the hospital setting. More and more treatment are coming out, so we'll talk about some of those. Confirming that 40 to 50% of the cases are asymptomatic. Confirming again that indoor transmission is the problem, not outdoor, and we'll talk a bit more about that. And what we don't know is when are we going to get an effective vaccine? I'll discuss some of the latest data there. And more data emerging that the mortality rate may be irrelevant as 0.5 to 3%, but really the long-term damage of 30 to 50% of people is really something to get worried about. So let's do the deep dive. Well, let's get the reality. What's the size of this virus? To give you an idea, this is a human hair, and that's between 50 to 70 microns. This is the size of a tiny bit of sand, and that's 90 microns. We're talking things that are 0.12 microns. It's not visible, and therefore they're floating in the air because they're so small. And we'll talk about some of the consequence of that. So that's the kind of the proportion we're talking about. So why is that important? Because we're going to talk about the symptoms and then how we control the infection. So on the symptom side, the World Health Organization as well as the CDC have been adding more and more symptoms. And unfortunately, some of them could be common to other diseases. What's very common is the loss of smell and taste. That's 60 to 80%, depending on the sources that have been published there. So if you start losing your sense of smell and taste, it is the leading indicator that you may be fighting the virus before any other symptoms emerge. Fever, we talked several videos ago that in New York, 80%, 77% of the patients going into the emergency room had no fever. So yes, it shows you have an infection, but it is not enough to know that you have COVID. The dry cough was the first symptoms, which is this really harsh cough that you get from deep into your lungs, and then the fatigue. So you can see some of the data there is really to look for the sense of smell. That is unique to these diseases there. And that's because the COVID is attaching to the ACE2 receptor. And the ACE2 receptor is the way it enters into the cell. And it turns out there's a lot of ACE2 receptor in the nose area there. So that's usually the point of entry. The most common symptom are headaches, congestion, and runny nose, which could look like a cold, unfortunately. So that could be confusing as we get into the winter. Because it could continue to develop, the dry cough could become a wet cough, and then all the problem that goes with shortness of breath and all of that. And then some people have reported diarrhea there, around 20% of the population. So you look at this long list of symptoms there, and as I said, it's not that obvious. And then the less common symptoms are dizziness and sore throat. So the more we're learning there, it's a long list of problems there, including eye pain and like pressure and redness in the eye. So especially for children there. So be on the lookout. Anything that's a combination of all of the above, you should probably get medical attention. So when you decide you should fight the hospital system, clearly what we know so far is shortness of breath and oxygen saturation less than 91% is what's called hypoxia, which means that the way our body works is that if your CO2 level is normal, even if you don't have enough oxygen, you may not be aware of it, and you have, basically have hypoxic and damage to the major heart and the brain there. So monitoring your O2 sat if you have any other symptoms, buying little pulse ox on Amazon, I highly recommend because that's one of the triggering there. Now they're discovering that having water retention in your ankle and any type of swelling may be an indicator that your kidney may be affected. Okay, that's something that just came out. And then, of course, we're discovering that it is really aggressive on attacking the heart. So any symptom that shows that you're having heart problem, arrhythmias, elevated heart rate, and all of that, it means you have an inflammation and a hypoxic event of the heart. And then there's a lot of blood clots. 25 to 40% of the people have blood clots, and that could create a stroke, a myocardia, a pulmonary embolism. So that's the one that have long-lasting problem there. So anything that looks like this, immediately go to the emergency room. So we also have discovered that there's an immune response for some people there, and people develop the skin rash. You may have heard about the COVID toes. The COVID toes is these very big red swollen toes, especially children have that, and a general fatigue. For the children there, we have this multi-inflammatory response. It does happen. It's pretty rare. I think it's several hundreds in the US compared to the number of cases. It's not a huge percentage, but keep an eye on that. They have different symptoms than the adults. So different symptom to look for. So what are the long-term effects? More and more data comes out every week, validating that it is going to be a bigger issue. And we may be talking millions of Americans that may have long-term effects, and that may be overwhelming the outpatient system as opposed to the inpatient system. So let's do a bit of a deep dive. Respiratory function. When they start looking at doing CT or X-ray of the lungs, they discover fibrosis and permanent damage of the lungs. Chinese study has shows 94%. And I spent at 94%, it's a stunning number, of people who have been hospitalized, so that's the 20% of people who get hospitalized, have residual, i.e. lasting, lung damage, okay? The French study showed that 23% of the patients were severe, i.e. people in a hospital setting, developed what's called acute pulmonary embolism, which could be fatal. That means you have a blood clot inside your lungs and you can no longer breathe, and that could be fatal in a matter of hours. And then 2 to 4% of survivors develop chronic, i.e. permanent pulmonary hypertension. So these numbers are pretty significant. Let's look at the brain fog. Wuhan showed that 36 to 46% of their patients develop neurological symptoms. And that could be transischemic attack or little blood clots that goes into your brain and then basically do mini strokes in the brain and kind of damage the brain cells, which shows you the memory problems, the heart, the difficulty in being able to focus. If we look at the heart and cardiology, we have hypertension and arrhythmia. Troponin is an indicator that there has been a cardiac injury. And so when they start doing the test of people in the hospital setting, they find out that 20% had a sign that they've had an injury to the heart. Some people have reported didn't feel fully recovered, so, after 2 months. And when they did a whole bunch of diagnostics, they find out that 78% using functional MRI and echocardiography had cardiac abnormalities. And that could be inflammation that could rescind itself over time. Like I'm sure you saw the news about, I think the pitcher of the Red Sox, had to stop playing because I think he's in his mid-30s there, he had a cardiac inflammation of his heart. And then in China, they showed 12 to 19% of the hospital patients have cardiac injuries. These are massive numbers, much more worrisome than just the mortality rate. Chronic fatigue is quite significant, and people have complained of 4 to 6 months of chronic fatigue. A persistent loss of smell, it takes 4 to 6 months to recover the loss of smell because you have to rebuild the nerve. And some of these have permanent damage to the heart and the kidneys and have to go on the kidney analysis. And the reason I mentioned this is it's just not to scare anybody, but just to say these are from mild to severe. These are not just the people who end up being intubated and have all this complication. And so therefore, please wear a mask because this could happen to you even if you have mild symptoms. And we're going to continue to look at this. Other data in Italy show that 87% of hospitalized patients had mild to severe long-term problem. That's a significant number. There is now an app that over 2 million people are starting to use that is studying the people after they recover. And pretty much people are saying that 10 to 15% are not recovering fast. UK is starting a 1-year study with 10,000 survivors to look at what they call the long shadow. UCSF here in San Francisco is starting a study for 2 years on 300 adults to try to learn what's happening. And this is the big news. There doesn't seem to be a correlation between acute and chronic symptoms. So in other words, the severity of the symptoms, the long-term symptoms, are not directly correlated to the severity of the symptoms you had when you had the acute crisis there. And to get a perspective, the SARS of 2003, which was a small amount of cases, but we have a lot of data about them, that around 20% had permanent injury 17 years later. So it's something we really need to keep an eye on, because when people say, I'm young, I'm invincible, no, you are not, and you may have long-term damage. And that's a much bigger worry than having a 2% chance or a 3% chance, whatever the number is, of dying. So please spread the word. So let's look at transmission. A study just came out that tried to quantify how you can get the disease, and we're going to do a deep dive on this. So there's 4 ways you can get COVID. One is from somebody who is symptomatic, i.e., they don't feel well. It's estimated that around 30% of the transmission are from a symptomatic person there. Let me say it the other way. That means 62% of the transmission is from somebody who doesn't know they have it or some other means. Okay? And that's the problem with this disease that is spreading, in the community by people not being aware they're contagious. Most of the way that gets transmitted when somebody is symptomatic is through the air. It's a cough, a sneeze. You're talking to somebody without a mask, or you're talking to a healthcare, if you're in the hospital, a healthcare professional, so basically get exposed to a patient there. So this is where we're doing a lot of the testing. We're doing massive testing. In nursing home, they're testing everybody once a week. And then there is the pre-symptomatic, which are people in the 0 to 3 days before they develop symptoms who are at the peak of their contagion. We'll talk more about this. That's estimated to be around 46% of the transmission is by somebody who is basically infectious, but they don't have symptoms yet. That's that period of 0 to 3 days there. And the issue with that is when you're talking to somebody nearby, they have a very high viral load, so it doesn't take too much for you to get exposed because that's the peak of the viral load. And then we have the asymptomatic, which people believe is around 10%. These people have no idea for the whole period that they ever had the disease. And it is perceived that they may shed, but not a lot. And the viral load that they shed may be low enough, so there may be a low infection rate there. But there's no testing for these people there. And then there is people are asking me, say, how can I get it from surface? And in this study, it's the first time I've seen that they estimate that around 6% of transmission is from surface. So the majority, 94% is from the airborne, from person to person there. So unfortunately, we have no way of testing this area there. Right now, all the testing we're doing is for people who are symptomatic or just want to be tested. Younger children, it turns out, it just came out that children that less than 5 years old may have up to 100 times more viral load in the nose. So they don't get as sick, and they have a very low mortality rate, but they are more contagious. They are carriers. We call them disease vectors. They are the one who is spreading the disease in the community there. And this is based on what's called the CT, the cycle threshold, which we'll talk a little bit more about, which is how many times do you have to amplify the sample to be able to be detectable. And so the lower the cycle, the more contagious you are. And you can see there's a very big differences between the less than 5 years old than the 5 to 17 who are as contagious as the adult. So that's really important there, because I think we need to make sure that the schools are safe, not for the children, but for the teacher and their parents. Let's do a bit of a deeper analysis there. This is when you have the symptoms. And from -3 days to the time you get your first symptoms, that is when you get the most contagious part. That is the problem. This is the viral load. And it's a huge amount of magnitude. And pretty much by day 5 after your symptoms, your viral load has dropped drastically. So this is when the people are the most contagious there. That's when you have the viral shedding and when people are contagious. And we have to understand that, because if you do a test over here, you may still have the PCR able to evaluate that you're infected, but that doesn't mean you're infectious. We need to distinguish between being infected and be infectious. So this is a graphic of the shedding. These are logarithmic scales. And you can see that pretty much at 10 days, you have a massive drop. And the period where the most contagious is the first 10 days from exposure. What does that mean? That means the transmission could be mostly in the air, and there's different type of sizes of aerosol. And if you have absolutely no protection, you can see how quickly everything goes into your lungs. And that's the danger of the asymptomatic people. They're not carrying any mask there because they can spread it, in less than 6 feet distance there. If you're both wearing masks, you're pretty much protected there in the aerosol. Let's look at size. Remember, we talk about this virus is tiny, 0.1 micron. It turns out that depending on the humidity and the environment, all of that, the respiratory fluid could be much bigger. And that has an impact in where the virus drops on the floor or stays in the air. And so the environment is really important. And we've talked in the past about the ventilation and the environment there. We need to really understand the impact it's totally linked to the infectious rate. So for example, if we have a very high humidity versus a very low humidity there, the size of the proteins are much smaller. What does that mean? That means the very low humidity environment there, it stays in the air longer, for hours. It also means it could go through your mask because most of the mask is 2.5 microns. And I've shown you this virus, when it's tiny, is significantly smaller than that. So you need to understand that the infectious environment is a function of the environment you're in. And to give you an idea, it's a busy graphic there, but it goes into the nose and then it goes into your lungs. And it goes deep into your lungs depending on the size of the particle. So if you're in a very dry humidity environment there, it goes deep in your lungs. And that's where, of course, which is a very dangerous part. And so what's influencing the size of the particles is the temperature, the humidity, the genetic, and if you are exposed to the sun, your ultraviolet will kill it. So it's really important there that if you look at the upper respiratory, this is where you get the infection there. It's usually the particles above 1 microns there. If you get into surface, some of these are really big particles there, and so they're easy to kill. But the tiny ones, that goes into the lower respiratory tract, that's this cough and this sneeze that gets this small particle that goes deep into your lungs. And so what does that mean? That means that the size of the droplets, if it's really tiny, means it can go really, really far. So if you have 5 micron droplets there, which is the green light, it can go 60 meters. That's a big distance. So I think the 6 feet, you want to make sure it doesn't give you a full sense of comfort because it depends on the environment you're in. And that means the less than 10 micron virus there could be in the air for many minutes to hours because it just floats longer. So be aware of your environment you're in. And we talked in prior videos about being, look at where the wind is coming so that you have the wind coming from behind you as opposed to be pushed towards you. So let's look at the surface. So the half-life is the time it takes for the virus to have 50% of the load to have dropped down in its curve. And what we've looked on copper, cardboard, and stainless steel, and all that is that they could last for several hours. But it's really, remember that probably less than 6% of infection are from surface. So what does that mean? That means we have sick buildings right now, and we need to really have an effort from where people work, which is the employers, as well as the school, about how can we make ventilation safer. And go back a couple of weeks ago, we did a deep dive on that. But it is now estimated that an indoor building has a 19-time higher risk than to being in the open air. So in the past, everything we did is to improve this building to be more energy efficient. So we seal the outdoor door. A lot of these buildings, you can't even open the windows. And they have low ventilation rate because we're trying to save energy. And that turns out to be exactly the opposite, of course, of what we need to do with COVID. We have problem in nursing home because most of these nursing homes have high density, don't have, very good ventilation there. And really, in my mind, we have been focusing in the last several months in the patient hospitals. We need to start focusing on how to keep people safe at home, which is 80% of the population, prevent transmission there. So, and unfortunately, we have a lot of issues on public health that they're totally underfunded. And we need to improve the testing, and we'll talk more about that. So let's look at the infection disease. If you look in the dark spot, these are the positive cases. And you can see that they are infectious really for a period of maybe 20 days in the worst case. On the average is around 10 days. That's that pocket we've been talking about. This is when people are contagious. And doing a deeper dive, I'm having a problem with my graphic here. Hold on. It turns out that somebody who has a mild case versus somebody who has a severe case is as infectious. So I repeat that. Somebody who is mild versus somebody who's going to end up with major complication is as infection during that first day period there. So that means everybody is contagious, not just people who have mild symptoms. We talked about the viral load and the concept of CT. And CT, the way that works is the number of cycles you have to do the PCR to basically detect if there is a virus there. So the lowest amount of cycles means you are the most amount of contagious. Now, this is important to understand because when we look at the sensitivity of the test, we are looking at really seeing, can they detect a tiny, tiny bit of viral load? Well, it turns out what we really need to do is something that's fast and quick because we want to detect when people are infectious. Not if they have the virus. What we want to see is that are they contagious is what we're looking for. And so what we want is people who are in this zone, not necessarily this zone. What does that mean? It turns out that the number of CD cycle is correlated to how infectious you are. So go back to the number of threshold there, and this is basically the percent of culture there, which means we need to change the way we do testing. So right now, everything we've done is the Cadillac. So we're using PCR, and this PCR is so sensitive that it can detect a small amount of virus. But remember, I've shown to you that if you have a small amount of virus, it's not really that critical. What you want to see is detect people who are contagious. These are the ones you want to quarantine. And we want to do it fast because a matter of a few days is a lot of people being exposed. So we need to develop what's called community surveillance, which are point of care, very quick tests that you can do at home, as opposed to spending several days. Right now, in several parts of the country, it takes 2 weeks to get the results of the PCR because they're so backlogged. That means it's useless. By that time, you have basically exposed everybody. And this is another interesting graphic. This shows that PCR accuracy goes down because the number of the viral load goes down with time. So to really, do the testing in this time period is irrelevant because what's more important is to look at the antibodies. Remember these two curves. You start developing antibody and you start peaking around day 20. This is when you peak the antibodies there, where your viral load goes drastically down after 10 days. So what we need to do is to get quick turnaround time in this area there, which is when people are the most contagious. So this is what we need to do is right after we have any suspicion of being exposed there is to do this quick test to just see, that you don't need that sensitivity of the Cadillac. You just need something that's fast and cheap that can give you quick turnaround in 24 hours. So what we're looking for is frequency and turnaround time, not sensitivity. And that's something that the dialogue is starting to change in the country about that. Because we want to catch, as you're getting infectious there, this is when you want to find out as quickly as possible so you don't expose all these people here. And that's how we stop the spread of the virus. So we're developing at-home collected test to do the PCR. This is one, that's out there. It still takes several days. People have not fully gone through the FDA yet to get the approval of a lower accuracy test. But I think the industry is starting to realize that we don't want to be compared to the Cadillac and do it faster. We need to get something that, gives you feedback so you can isolate yourself. We talk about the pool testing. The pool testing, the FDA has approved that you take 4 samples, put them all together, and test on the PCR. And the idea is that will kind of stop the backlog problem we're having. But that only works if the prevalence is less than 5%. Because otherwise, you do the math on how many times you have to retest it, and it doesn't work. And unfortunately, you can see the prevalence in the US overall is 8%, and in several states, it's over 10 to 20%. So we're not really, we're going to start the pooling, but that means we have to redo the testing more often just because the prevalence is so high right now in the US. Now, for the fun of it, I just discovered that the dogs, people who know me knows I have 2 German Shepherds, they discovered they have a 92% accuracy. And so in Dubai, they're starting using dogs if you fly there, and they take a sample from your armpit, It's very quickly being collected there and goes into this funnel there. And there's a dog on the other side with a 92% accuracy to triage you. And then if it works, they do a nasal PCR test, which is on site. And so we need more dogs. K95, what a mess. The N95 is the test that's being used in hospital setting that has a 95% protection from you to be exposed from somebody from the outside so you don't breathe it in. It also protects people the other way around. And unfortunately, when we had the shortage, the FDA quickly approved over 3,500 Chinese manufacturers in a matter of a few weeks. Some of them were in business for less than 5 days, so you can clearly see there was one post office after another that got started there. And most of them failed quality testing. And the US now has bought millions of those, and we don't even know if they're any good, the testing. In most of the cases, that 60% of them failed the testing. So do not buy K95, pay the premium to get an N95 because you really don't know. You can see the registration peaked. I mean, there was unfortunately a gold rush there. And so the FDA now is cutting down drastically in the number of approved vendors there, but there's this whole garbage that's in the system. So really be careful. Let's look about what's going on with treatment. As a quick summary, we discussed the viral load kind of goes up and then peak at around 7 to 10 days, and then you start having the antibodies that start to kick in there. So the way we're treating people is during the period that you are having a virus growth is to use antiviral and immune boosters. And if you end up in the hospitals there, then we treat you for the cytokine response. A week ago on the July the 31st video, we did a really deep dive on all the different treatments. So I'm not going to repeat that. I'm just going to add to that. So if you haven't seen that video, please go back and take a look at that video. At the high level, there's 4 categories. One is to basically help your immune system, and that's the plasma antibodies, the monoclonal antibody. I'll talk about that in interference. So there's new news on that. We also try to, as you're having the cytokine storm, we use existing drugs to decrease your overactive immune system. We also have learned that we need to optimize ventilation, not put you on a ventilator. That's kind of the last resort. And also try to mitigate the damage of the blood clots, which is the anticoagulants. So what are the new drugs? So there's an HIV drugs done by a company called Cytodine that's in phase 3 trial at Baylor Medical Center in Texas that hopefully will decrease some of the lung inflammation. Interestingly enough, there's a drug that has been approved by the FDA for leprosa, and which is the deformation that you may know with the skin, and it seems to be blocking the viral replication. And that would be great news because we have a lot of safety data about that drug, and that's being tested in the US. This is a combination of a Pepcid, which is an acid controller, with Celebrex, which is a drug that's also approved for arthritis. And what it seems to be showing is that the combination of those 2 drugs put together, and there's a study going on at Beloit Memorial Hospital there, show that there's a drastically a better recovery of this patient with better blood tests, which means that the body seems to have a better response system. Monoclonal antibody, Eli Lilly, a very big pharma company there, is doing 2 drug trials. So typically you inject an antigen into a cell, into a mouse, and then you collect those cells and you amplify them and you inject them. So it's an infusion into the patient there. They're now doing testing on 220 volunteers for mild to moderate. So this would be an outpatient treatment, which we so desperately need. And then they're doing another trial on 1,000 patients in the hospitals there that have less than 13 days symptoms. So they're not really into the severe category yet. And what they did is that they took a sample of a survivor several months ago, they synthesized it, and they're making a synthetic version of that antibody that survivor had. Triple therapy just has emerged. And we talked a few months ago about ivermectin. Ivermectin is this antiparasitic that is approved in the FDA for animals and is being used in third world country for people in South America and all of that who have some other parasites on their head. And combining it with doxycycline, which is approved antibiotic for acne and urinary tract infection, in India and Bangladesh, they have shown very good efficacy in using that combination on an outpatient setting there. And they added that vitamin D3 and C, which is things we've talked in the past can be protective. There are trials in Australia and also a trial now in the US to see if these 2 cheap drugs that we really know very well, could be effective. The FDA has issued a warning just because they claim that the dose could be dangerous and they don't want people to use it off label right now until there is more data. We don't want to repeat the hydroxychloroquine saga. Convalescent plasma is doing great. There's been over 53,000 people who have had it. That's a massive amount in the US. The deaths has gone down by 36%. It's people usually get the plasma within 3 days after being diagnosed, usually after they've been admitted to the hospital there. Mayo Clinic is doing a massive study on 3,000 patients showing that after seven days, they cut, the mortality rate drastically there. So, but to be cautious, these are observational study. There is no placebo, no peer review. So hopefully, and it's very expensive, so it's going to be used for severe patients who are in trouble. Interferon, there's a UK is developing an inhaler that can be used at home for treatment. Again, we need more treatment at home, and so that's very promising. And that could be something that stops the inflammation response that people are having and avoid them to be in a hospital. Remdesivir, which is the drug from Gilead, is in allocation. They cannot make them fast enough, and there's a lot of controversy about, should we allow other people than Gilead to manufacture? Gilead claimed that by October, they should be able to have manufacturing capability for the world demand, so we'll see. The data is pretty encouraging. If people were receiving oxygen, you can see there's really an improvement in the outcome of the placebo versus remdesivir in the percent of people who have recovered. There was not too much of a delta for people who are not receiving oxygen. So right now, it's only restricted to patients who are on oxygen therapy in the hospital setting. Dexamethasone is this very cheap drug that the British have discovered is very effective at stopping that cytokine storm and has huge results. I mean, look at the data there. It's like the mortality rate is 29% versus 41%. That's a massive drop in mortality rate. But again, it only works for people on ventilator. So it's not something that could be used for people who have mild to moderate cases. This is new and it's controversial, so I'm just going to mention this, but there is a group of physicians in the US call themselves the Frontline COVID-19 Critical Care Alliance. And it's 10 critical care specialists that started with Eastern Virginia Medical School in Norfolk. And they put together this cocktail, which is methylprednisone, which is a form of steroid. And remember the drug we just talked about, is a form of the dexamethasone is a form of cortisone, so it's a different type of cortisone. They add to that high dose of vitamin C, thiamine, which is vitamin B1, and heparin, which is a blood thinner. And what they've been doing is that they also, the plus for the math plus, so this is MATH, you can see it going down, they had vitamin D, zinc, and melatonin, which we talked last time could be helpful. They claim that this has a big impact for patients to help them manage the disease. It's still being evaluated. There are some physicians who say, you need to get more data there. But if this works, these are a very easy cocktail that doesn't cost too much money that we could give to mild to medium cases. Prevention intervention, as we mentioned earlier, please make sure you have an oximeter at home and measure it regularly there. Vitamins, there's a lot of data we've covered in the past that D3, vitamin C, and B12, magnesium, and zinc are helping your immune system in protecting yourself before or after you just got exposed. And study recently have shown that omega-3 fatty acids can help turn off that inflammation response that you're having there. And melatonin also seems to have some data that can also decrease some of the cytokine storm. So these are easy things you can do at home if you want to be proactive. Vitamin D data, the B3, has been shown to be really effective in an Israeli study there. So that's another thing that most people over the age of 65, 50% have vitamin D deficiency. Easy things that you could do proactively. Let's talk about the vaccine. I'm not going to spend huge time, but just a quick reminder. The virus enters the cells attaching to the ACE2 receptors, which is the problem because there's ACE2 receptor everywhere in the body. It goes inside the cell and it duplicates itself. And that's when you have that viral explosion there. And then it starts invading other type of cells. This is when the immune system recognizes there is an invader. And we have two types of response. We have the antibody, the B cells, and these are the ones that try to block the virus by attaching to the spikes, which is the one that enters the cell to stop the propagation. And then there's T cells we've been talking over the last several weeks, and that's the one that detect a cell that's infected and kill that cell so it can stop the duplication of the virus. So we have two different responses in how we respond to a virus attack. Why is that important? If the data has come out about the type of antibodies, which is a hemoglobin G, is the strongest one that comes, and you can see that there's not too much in that first 7 days, which is why some people lose that cytokine storm response. And then we start to peak around 14 to 20 days, and when you have that very strong antibody response, and 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 how long does it last? And that has been the big question. Data just got published that shows that depending on severity level of the response you had to COVID, you have a high amount of antibody. And this is a log scale, so it's pretty significant. That's a 10x difference. And of course, it makes sense. The more severe you are, which is the red, and you will expect a high response there. And what this is showing is that there is a link there, but it's not necessarily direct correlation to the severity. And it also shows that we've seen in other data, it drops down after 40 to 60 days. And that's why we start talking about the T cells. If you're interested in participating in a trial, this is the website. You can sign up and you can volunteer to be part of those COVID trials. There's already 150,000 people who've signed up, but some of these trials need 30,000 per trial. So there's a need there. Now, to keep perspective, the definition of an effective trials by the FDA means that 50% of the time it's effective. And I want to emphasize that because that's the definition of the flu vaccine. So if you take that vaccine, that doesn't mean you're 100% protected. That means half the time it helps you. I think it's important to understand that. So people who participate in this trial, they could get payment of a few $100s to thousands of dollars of payment to participate in trials because you have to do a lot of testing and follow-up afterwards. If you do get an adverse event, typically they reimburse your insurance company. It doesn't mean you get more money. And then there's this big controversy to say, do we just vaccinate people and see if they get COVID, or do we expose them to COVID? And this is what we call a challenge trial. And of course, you can see that's very ethically challenged because we don't have a treatment for COVID. And so there's a lot of discussion there on how to can facilitate the testing of this vaccine in maybe other countries like Brazil, where there's a very high rate of the virus. And so therefore, it'll be a higher exposure rate. Quick summary there, there's different type of vaccine. Most of the mRNA need 2 injections at 28 days apart. Other ones are pill-based and you just need it once. So don't assume that every vaccine is the same. There's probably going to be multiple vaccines that are going to be approved. And then depending on your situation, there some may be more adequate than others there. All the mRNA, we've never made an mRNA vaccine. There's a lot of uncertainty in the manufacturing process and the logistics process of mRNA. These are the first one who are getting trials. And again, please go back to last week. We spent a lot of time on that. So I'm not going to repeat that. But there's some interesting data I want to share. This is looking at that T cells respond. The T cells, as we discussed, that's the long-term immune response system. That's the one that with SARS showed that last 17 years so far. SARS was in 2003, where the antibody goes away, as we can tell, after a few months. And what we want when we do this vaccine testing is to see not only antibody, which is the short-term response, but more importantly, the long-term response, because this virus is going to be here for a while. All of them show an increase in T cells, which is very promising. You can see at day 1, not too much. Day 29, there's a second injection. And you can see at day 49, but it's not exactly clear cut. So that's Moderna. And you can see the other, the other 3 top vaccine there, they're all seeing a pretty strong increase post-vaccination there. So they all looks very promising there, but these are still small samples. And then what we are learning is that you may have that first immune system response, but then it may go away after 3 to 6 months. So what they are now doing is doing an adjuvant or booster, where you get a second infection that is a carrier that will help you keep this antibody longer into the body there. So you see a lot of those drugs now are a combination of the vaccine with an adjuvant that give you that boost so it lasts longer. So this is the end of my second video. I really appreciate you listening. If you haven't seen my first one on the virus spreading across the world, please take a look and post this to your friends who want to spread the knowledge and help people to change behavior. Thank you and see you next week.